All right, welcome everyone to our first session in our Geriatric Bootcamp series, week 1. This week is our kickoff session, so we're going to be talking a bit about what the series is going to entail. We have Dr. Lynn McNichol here who is with us. She's a professor of medicine at Brown University. Super excited to have her with us. She brings an esteemed group of colleagues who is going to be walking us through a lot of different various geriatric conditions that we see in nursing homes that are prevalent. If you could go over to the next slide for me, please, Lynn. Before we get started, though, I'd like to talk a little bit about who the iPro QIN-QIO is, if you're not familiar. iPro holds the federally funded Medicare QIO contract for the regions shown here. iPro specifically helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the iPro QIN-QIO banner. So if anyone asks if you're working with iPro, you say yes. Next slide, please. At this point, we'd like to give a COVID-19 update. We have seen an increase in hospitalizations related to COVID-19. I know the majority of the world has said that COVID is over, but that's not the case for our long-term care facilities. We're seeing that increase in COVID-19 infections as well as deaths. There are some new variants that are the Eris variant that is currently becoming more prevalent, and we are continuing to work and get those vaccine updates, and we're expected to have those vaccines available to everyone within September. So more to come on that as we work through the continuation of our series. We should have continued to provide some updates related to COVID. At this point, I'd like to pass it over to you, Lynn. Thank you so much.
Thank you, Joshua, and welcome everyone. Thank you for joining us for our Geriatric Bootcamp Kickoff. I'm really excited to be part of this team that's going to present you some geriatric topics, increase your knowledge of geriatrics, and hopefully help care for our patients better. So we're going to review some basic principles of the comprehensive geriatric assessment and how it relates between aging, disease, and frailty. We're going to talk about how we interpret the medical literature, which can be a challenge for our skilled and long-term care residents. How do we talk about preventive care in routine practice? And then briefly touch upon the top 10 reasons for readmissions in the Northeast. So just as Joshua mentioned, we're going to be talking about some practical, common medical and surgical conditions, as well as some aging principles during our series. We have a great team of academic geriatricians and providers who take care of nursing home residents, but also teach and perform research in this area. So you'll get the latest and up-to-date information. We've divided it into skilled care topics and long-term care topics, but of course they overlap. Our long-term care residents often have surgery, and our skilled care residents also have chronic conditions that we need to manage. So we've divided it, but it's really going to be for all types of residents. So these are the areas that we've decided to touch upon. We'll talk about post-op management, delirium, trauma care, specifically as it relates to hip fractures, rib fractures, and head injuries, acute GI bleed, kidney-related injury and urinary retention, heart failure, which is extremely important, and UTIs. And then for long-term care topics, we're going to talk about Parkinson's, diabetes, dysphagia, polypharmacy, and deprescribing, stroke, and in the context of all of this, we're going to finish off with the staff retention and training, because hopefully you will use this new information to spread your knowledge throughout your facility. So what are the key issues related to a proper comprehensive geriatric assessment? So what do we do as geriatricians when we see a new resident or need to do a comprehensive geriatric assessment. So of course we need the full medical, the full surgical, as well as problem-based assessment. So what are their specific symptoms and complaints, but also in the context of their psychological as well as social determinants of health. So what are some of the key aspects in their care, in their life that is driving their health? We have to assess cognition, of course, we have to assess function, and I can't emphasize enough the medication review, which can be quite complicated, especially if you're in a skilled rehab and you don't have complete access to the hospital record. So, but in addition, we want to think about underprescribing. We want to think about over-the-counter medications in our skilled patients and what has happened in their medication regimen lately. So has their primary care doctor changed something? What happened in the hospital? What has been done by other members of your team, your APPs, your coverage doctors? What changes have they made that might be impacting their care? And of course, I can't not mention the Beers list, which is the American Geriatric Society Beers list, which you can access online, which lists all the potentially inappropriate medications that you need to review. And we think of diseases, but they all interact, right? The medications, their diseases, their functional and cognitive abilities, all sometimes work together or against each other. So you can't treat the heart failure without potentially making their kidneys worse. And so you need to have it all in mind. And the way that I see it is you have to view the patient from the 60,000 foot level, but also be able to hone into the details so that you're paying attention to the details while also having the big picture in mind. So this is another way of looking at it, which I like as well. So you've got sort of we do the comprehensive assessment, which we just talked about. But I also mentioned hearing and vision, which is really important, and affect. But we also talk about social determinants of health. How can we make things better, especially for a skilled resident that we will be sending back home? And we need to make sure they have a home, they have money to pay for their medications, they have insurance to pay for visiting nurses and so forth. All of this is in the context of shared decision-making, right? So we're no longer a patriarchal type of healthcare system. We make decisions together as a group. That may include the patient, the family members, their caregivers, other clinicians, so that we're all on the same page about how to manage these issues. The way I think of it is I'm often the translator. I translate things that the patient tells me to the other providers, and then I translate what the other providers are trying to say to the patient or resident. So making sure that everybody is on the same page. And you also have to consider the value proposition. So it's not always clear to us if an intervention that we're doing is going to help or harm them. And sometimes we have to figure that out as we go along based on whatever medical literature we have available, but also in the context of their health, their age, their potential for survival, especially when we're getting into the old, we're getting into people who are in their upper 90s, it can make things much more complicated in figuring out if we're helping or harming them for simple decisions like blood pressure management or whether we should investigate a pulmonary nodule, etc. Goals of care conversations are really important. They are essential for any proper care of any of our residents. And then communicating across all of our team, including the nursing home staff, so that we all understand what's the care for this particular person, but also the primary care if they're going back home, and their surgical specialists. So this is just a demonstration of how different it is to care for a younger adult versus an older person and how disease typically progresses. So in a younger adult, they might have one disease. diabetes, and they have one pathophysiology, they have a set of symptoms related to that disease, and then there's a specific treatment. In the older person, there's multiple pathologies, right? Typically multiple organs involved in different pathologies. You also have the pure aging syndrome, which of course they lose about 1% per year after the age of 30 of most of their organs, including their kidney, their heart, their lungs, their brain. So if they're 80, then essentially they've lost 50% of their kidney function already. Now we do have 80% reserve. So we still have some reserve capacity, but when they get older and then you tack on some disease, then the pure aging and the disease interact to make us get rid of that reserve capacity. Of course, they have a lifetime of socioeconomic and environmental factors, as well as habits, lifestyle, and behaviors. All of this interacts and creates a cascade of problems, which leads to common, often symptoms, functional loss, and disability. So the concept of geriatric syndrome is very important for us to understand. And it is often what we think of it as multiple risk factors leading to increased risk for a symptom or disease. So for example, falls is a classic geriatric syndrome. So most younger people who fall is because they tripped on a wire or some other one risk factor. But in the older adult, it's not usually that simple. There might be multiple reasons that put them at risk for falling. They might have tripped on a wire, they might have vision issues, they might have inner ear issues, they might be on medications, they might have sensory problems in their feet and proprioception, they might have had a stroke, they might have Parkinson's, all of those things interact. And the middle section is where we used to think was sort of the model. All of these risk factors lead to a particular geriatric syndrome, such as a fall. But we actually understand now that it's more of the model on the right, the interactive concentric. So there are multiple risk factors that often act synergistically so that they multiply a little bit. So it's not 1 + 1 = 2, it's actually 1 + 1 = 4. And so that if I have neuropathy and I'm on a medication that makes me ataxic, that significantly increases my risk of a fall compared to just one of the other factor. I can't mention anything about geriatrics without mentioning my favorite older adult, which was Jeanne Mance-Calment, who is the oldest person that we know of to have ever lived at 122.5 years of age. She died in 1997. She was a remarkable woman who, rode her bicycle until she was 100. She dictated her autobiography at 115, had perfect memory. And of course, had a hip fracture repair at 115, probably the oldest person to have ever lived to have a hip fracture. So she was remarkable, and she is sort of my role model for healthy aging as best as possible. So we talk about geriatric syndromes and all the risk factors. Well, there are some that are non-modifiable and there are some that are modifiable. So if we can fix vision impairment, we can address medication issues that can increase our risk of these risk factors. We can do some therapy to improve lower extremity weakness and gait and balance. We can do some occupational therapy for ADL impairments. And use assistive devices and maybe treat depression, hopefully non-pharmacologically. And then you have to remember that frailty, we often think of this, very thin, wheelchair bound, isolated, lonely, sort of living in their own little world. But this is also frailty, and we have to recognize that obese people can also be frail, and it's actually potentially even worse than if you're thin because you have more weight to carry and less muscle mass to carry that weight with. So a few slides about failure to thrive and frailty. So failure to thrive is something that's kind of coming out of favor, but it's something that sort of encompasses frailty. but also cognitive impairment and functional disability together. And it often also includes weight loss, decreased appetite, and nutrition. So I'll show a slide that sort of incorporates that a bit. But in frailty, it's something that is more and more research about, and it's something that we should be screening much more commonly for. We often think, as most nursing home residents could be considered frail just for the fact that they need to be in a nursing home. But what it really means is a decreased physiological reserve. We talked about reserve capacity. When we become frail, we're really at the edge of our reserve capacity, and it usually involves multiple systems. And where aging and disease both interact, lead to that impaired function, and it often is associated with malnutrition and weight loss. We talked about sarcopenia, but it's really a very important aspect of frailty, in that you get such a decreased muscle loss that it actually promotes further muscle loss with these diminished anabolic signals and decrease in growth hormone and testosterone, and it promotes catabolic signals. So it promotes the activation of hormones that use up fat and muscle. And the muscle fibers get replaced with fat and fibrotic tissues. And this is what it looks like on imaging. You know, the left is a perfectly healthy thigh with lots of muscle, little fat. And the right is an older thigh with sarcopenia, and it's almost the same size, right? So if you look at the size of the thigh, it looks fine, but it's 50% muscle, 50% fat, essentially. And sarcopenic obesity, as we talked about, is really a very difficult thing to deal with in our rehab population and in our long-term care residents, where they have an increase in fat, a decrease in lean muscle, and their metabolic rate is decreased. And they might, you don't want to miss undernourishment or malnutrition in this patient population, especially perioperatively. This is just a diagram that shows the interaction between frailty, disability, impaired neuropsychiatric function, and in the middle is failure to thrive, where they sort of continue to decline and further, and then ultimately can result in death. I like this slide because it shows you sort of the cyclical pattern of sarcopenia and undernutrition and decreased function, and it sort of feeds onto itself. So, for example, at the right-hand side, you have a disease, whether it's a hip fracture or pneumonia, you get bedbound, you lose muscle mass. That leads to decreased resting metabolic rate, decreased strength and power, decreased VO2 max, which is your pulmonary capacity. Then you walk less, you do less, you decrease your total energy expenditure. That actually can contribute to anorexia. And on top of that, you have anorexia of aging. So then you get more undernutrition, you get inadequate intake of proteins and energy, you get deficiencies, and that leads to more sarcopenia, and that becomes a vicious cycle. So we need to break that cycle. And there's lots of different ways that we can break that cycle. We can do physical therapy. We can implement nutritional interventions. We can get them more socially involved. We can get them moving out of their beds, out of their chairs, out of their rooms. So I'm a very optimistic person, and I don't believe that this is inevitable. I believe you can intervene. So this is just a way of looking at frailty. You have the robust individual on the left, and then you often become pre-frail and then frail. And people on the top graph, they can decline fairly smoothly and gradually. Sometimes in the middle section, this is what happens when you have like an event. You have heart failure, for example, then you kind of stabilize for a little bit, and then you have a further decline. And then the tertiary generally happens when you have a more aggressive, like cancer, and you become frail pretty fast. So let me talk a bit about the medical literature and our challenges with that. So I think they do fail the nursing home resident. There is not a lot of research that's done that's very robust in the nursing home resident. There's more and more, but it tends to be more retrospective studies, which is harder to interpret. And it's not as robust as a placebo-controlled randomized controlled trial. And so, and even when they do studies on nursing home residents, they tend to use the best of nursing home residents, or the most simple cases. So if they're doing research on dementia, they'll have dementia residents who don't have heart disease, don't have cancer, don't have anything else except for their dementia. When we know that we have complex people, they don't just have one disease, they don't have just frailty, they have a combination of issues. And it's really hard to interpret the literature for a typical nursing home resident. And going back to that value proposition, it just makes it very difficult for us to guide our residents and family members in making decisions that are in the person's best interest. So I wanted to briefly talk about preventive care. It's something that we don't often talk about, and it's something that we're not very good at doing, to be honest. And unless you're very vigilant of doing annual evaluations and including preventive care in there, it's something that often gets missed. But also, given our patient population in the nursing home and long-term care tends to be older, so they don't meet criteria for screening, for example, for cancer. As you can see, breast and colon cancer, we stopped doing routine cancer screening at age 75, and cervical cancer at 65. So we're not going to be doing cancer screening for a lot of people. But even in our younger nursing home residents who don't meet the age cutoff, they're often either their life expectancy is less or they're more frail to start with. So you have to figure out how to interpret their condition for this. So what I use is e-prognosis, and that's used to estimate life expectancy in younger individuals. And you can plug in a few variables and it lets you know the likelihood of this person living 5 years, 10 years. And it also tells you whether this person should have cancer screening or not. Because for example, breast and colon cancer, you need a 10-year life expectancy to benefit from the intervention. So if you've got a 70-year-old and they're not expected to live more than 5 years, then it would not be indicated to do any cancer screening in that person. For other topics, so bone densities is an interesting one because the time to benefit for osteoporosis treatment is 1 year. So all you need is a 1-year life expectancy to potentially benefit from treatment. So it's often worthwhile to doing a bone density. And it's often something, well, many of them already have a diagnosis of osteoporosis and could already be on a treatment. But if they haven't, then it's something that you might want to investigate or order. For diabetics, neuropathy checks, renal proteinuria checks, eye exams are indicated, until they have, less than 1 year life expectancy. And of course, I'm not going to go into the vaccinations. We don't have time today, but in most instances, except perhaps for Tdap, it's beneficial that they get those treatments, those interventions. So just briefly about readmission reduction strategies. There are strategies, and we're not going to go into detail about them, but one of them is to do exactly what you're doing now in terms of learning about medical diseases and how to manage them well, but then spreading that information to your staff so that they become empowered and more comfortable managing our complicated residents. The other is something that many of you are probably engaged with, which is the IHI Age-Friendly Initiative to make health systems more age-friendly. And if you might know already that they have 4 or 5 pillars. They call them the 4 M's or 5 M's. And the 4 M's, which are the core, are what matters, referring to what's the most important thing for that resident. Medications, we talked about the Beers list or other medications that might be an issue, mobility, get them up walking, and mentation. And in a nursing home, typically we're referring to dementia management, prevention, and improvement. And the fifth M is multimorbidity, which is a bit more complicated because obviously most of our residents are multimorbid. These are the top 10 reasons for readmissions for the New England area. And many of these we'll be talking about during our series, including heart failure, acute renal failure, urinary tract infections, gastrointestinal hemorrhage, diabetes. So we're going to address many of these issues during this series, and hopefully as you gain knowledge, you'll be able to manage them better. So in summary, great geriatric care involves seeing the resident in their totality, holistically. It involves anticipating and preventing complications. When nothing happens, we've done our job as geriatricians, as geriatric providers. And unfortunately, the literature offers us limited information, and we end up having to extrapolate in large part. But that's the skill of geriatrics and gerontology nursing. Thank you very much, and I appreciate your attention. Thank you.